On behalf of the Patient Safety Authority, I'd like to welcome you to this webinar titled From Burnout to Resiliency. My name is Bob Yonish, and I'll be your moderator for this program. Now I'd like to introduce our speakers for the webinar, Dr. Stanton Smullens and his wife, SaraKay Smullens. Dr. Stanton Smullens received his undergraduate education at Harvard College and earned his medical degree from the Sidney Kimmel Medical College, where he is a clinical professor of surgery and is board certified in general, thoracic, and vascular surgery. He was in active surgical practice at Thomas Jefferson University Hospital for 27 years and has been the president of the medical staff as well as the president of the Jefferson Alumni Association. In 1994, he became the founding president and CEO of JeffCare, the physician hospital organization of Thomas Jefferson University Hospital. Following his clinical activities, Dr. Smullens became the chief medical officer of the former Jefferson Health System from 1997 until 2014. In 2015, he became the chief medical officer of the Delaware Valley Accountable Care Organization, DVACO, and served as the medical director of Network Performance and Quality of DVACO until stepping down in 2016. Dr. Smullens has been a lecturer at the Sidney Kimmel Medical School of Thomas Jefferson University since 2016. In 2002, Dr. Smullens was appointed to the 11-person Pennsylvania Patient Safety Authority Board, where he has held numerous positions, including appointment as the chairman of the authority by Governor Wolf on May 24, 2018. SaraKay Smullens is a social worker, family therapist, and best-selling author. A diplomate in clinical social work, she is certified as both family life educator and group psychotherapist, as well as a contributor to peer-reviewed literature and local and national press. She believes that insight, awareness, compassion, creativity, and hope are necessary components to achieving what she defines as an emotional sense of direction vital to achieving fulfillment in a complex, often ruthless society. SaraKay has written several books, including Burnout and Self-Care in Social Work, a guidebook for students and those in mental health and related professions, which examines primary factors leading to burnout, and the individualized self-care strategies, activities, and attitudes that address and prevent it. During the past 2 years, her efforts to educate about burnout and self-care have taken her to settings in this country and abroad. A recipient of both a Social Worker of the Year and Lifetime Achievement Award from NASWPA, last fall, SaraKay was one of 6 chosen for the newly designated inaugural Hall of Fame of her graduate school alma mater, the University of Pennsylvania School of Social Policy and Practice. Dr. Smullens, I'll now turn the program over to you.
Thank you.
Hi, everybody.
Hi.
Good to be with you.
We started to say that we thought it would be helpful for you to know the background of this presentation and why it was developed. In the 5 years of research SaraKay did for her book on burnout, she found a great deal of information about healthcare professional burnout, depression, and suicide. In my work with quality and patient safety, concern about burnout and its effect on quality and patient safety are growing.
Our impetus has been to put together the best research we could find in medical, psychological, and social science literature to help address the alarming realities of today. We're trying to offer some different perspectives and framings than those usually presented. So here goes. Our title is From Burnout to Resiliency, but it also could be From Compassion Fatigue to Compassion Satisfaction. The challenge: to bend, to be flexible, but to be determined not to break.
These are the learning objectives, and after the session, we hope that you can differentiate between the macro and micro causes of burnout, recognize the interactive loop between personal, professional, social, and physical manifestations of burnout, and then to be able to describe personal, professional, social, and physical self-care strategies, activities, and attitudes to address and prevent burnout.
Literature defines burnout primarily as work-related, but Stan and my premise is more expansive. We're going to address macro and micro factors that lead to burnout, and we're going to stress the personal, professional, social, and physical interactive loop that goes on to develop into burnout. We're going to talk about the importance of resilience, the attention to this interactive loop, and the self-care strategies to address and prevent burnout. And our perspective and balance will be an emphasis on the importance of the healthcare professional-patient relationships. Okay, is this familiar?
I think it may be familiar to all of you. It says medical personality, but I think it could be anyone in the healthcare profession. We tend to be workaholics, and our response to a challenge is just to work harder. You feel like every challenge or problem sits on your shoulders, and you must be the one with all the answers. You have to be a perfectionist. You can't stand the thought of making a mistake ever.
Ever.
And hold everyone around you to the same standard. And unfortunately, many of us work as lone rangers. You must do everything yourself and end up micromanaging everyone around you.
Our premise is that the institution can and should provide support, but more about this later.
So we're going to talk about the macro factors. Certainly, society at large, the changes that are going on are amazingly complex. Healthcare is changing, as you know, dramatically. The electronic health record, value from volume to value, the incorporation of different insurance companies, the changing configuration of hospitals, practices, and then the institutions are changing, the department, and also your office practice. Each of these areas affect us. These are the macro factors that will affect us.
This slide could take our entire hour, and I'm going to have to be very brief. In 1963, of course, Freudenberger wrote The Feminine Mystique, where she explained that women wanted a choice to be able to join intellectually, academically, professionally, with respect. We see the confusion today and the upheaval of the Me Too movement. In 1970, as everything around us was changing, Sidney Garfield, an eminent physician, spoke about the worried well in his practice. They weren't ill, but something was terribly wrong with their perspectives. And Alvin Toffler, the first futurist in 1970, wrote about the future shock of today, what we're all facing now. 24/7 availability, a technological revolution that has led to a severely limited attention span. In many ways, of course, this revolution is wonderful because Stan and I can speak with you today, which is a privilege. But in other ways, the revolution is man's latest isolation booth. I equal isolation. Dr. Freudenberger, Herbert Freudenberger, in 1974, coined the term burnout. What we know about healthy anxiety is that anxiety alerts us, and when we're concerned about something, if in our family, if in our place of work, we can address this with someone, we will flourish. But when there's no one with whom to discuss anxiety, or if anxiety is posed from the top, we are open to burnout in the wings for all of us. Today, as you all know, kindness is seen as old-fashioned. There's an emphasis on being number one or you're nothing. There's the death of neighborhoods. There is the deep societal divisions and lack of compromise. Speaking about lack of an understanding the importance, how essential compromise is, speaking about attention span, I wish I could see each of you, but I'm asking you and I'm asking my husband, Stan, what do you think man's average attention span is today?
40 seconds.
Lower.
15.
Lower. 8.5 seconds, which is less than a goldfish.
This is amazing.
Yes. So,
this is a picture from the latest Medscape National Physician Burnout and Depression and Suicide Report, which was released earlier this year. This study encompasses approximately 15,000 physicians of different specialties, and we're going to look at the factors that have played on the healthcare community. This is a question that was asked of the physicians that were surveyed. The question was, how many are burned out or felt burned out, and how many were depressed? Now, the 44% is an average of all specialties. Certain specialties tend to ride higher. Certainly those in the emergency room, intensive care, these tend to be higher. But overall, it was 44%. 11% said they were colloquially depressed or situationally depressed. But clinical depression was 4%. Totally inoperative people frequently unable to function in any way, and many patients needed medications.
Do you think this is an accurate determination?
I think it may very well be.
I think that more people are burned out and depressed than are saying so.
Interesting, yeah. May very well be. This is what contributes most to burnout. Now, you can look through these, and I'm sure you could think of many of these, but basically the top one was too many bureaucratic tasks, charting, paperwork, time at work, computerization, respect from colleagues, administrators, not enough money, lack of autonomy, and so on. As you know, many physicians take 2 hours of work home just to catch up on their charting, and they spend more time with charts in the electronic health record than they actually do with patients.
And personal and family time is eroded from these enormous responsibilities.
Yes. Now, these are the causes of nurse burnout, and you'll see there are many similarities, but importantly, there are some other issues. Again, it's a high-stress workplace, the hours, nursing fatigue, staffing issues, particularly with the high nurse-patient ratios, and then bullying and incivility. Bullying from perhaps supervisors, certainly from nurses, and then the respect from they're working with, and from physicians, yes. And then again, the same issues of work-life balance. Again, the higher the patient acuity and the demands, lack of proper mentoring and leadership. And this is from a review that was published recently as on nursing issues. This is another slide, which was from material from the PRC National Nursing Engagement Report, which was released very recently, actually in March of this year, in which they reported that 15.6% of all nurses reported feelings of burnout, with the percentage rising to 41% of unengaged nurses. And we will talk about this a little bit later. But some of the reasons that the nurses said was that they did not feel part of a team with their colleagues. Their morale was diminished, and they felt emotionally checked out from their work, which also ultimately affects their patient care. Other healthcare professionals have also shown signs of burnout. There's only been one study about physician assistants, but it suggests it has similar numbers to nurses. Medical students, 44% worldwide, and at least 50% in the United States say they're burned out, particularly as they get up in their third or fourth years. Medical residents, it's unbelievably high. 69% at a tertiary hospital has reported burnout. Now, that is an amazingly and distressing number.
Other micro-burnout factors involve our relationships with families, friends, and as we're saying, with colleagues, with patients. Patients can bully nurses. I've seen it regularly, and often the nurses don't get the support and the protection they need in their environments. And within ourselves, Dan and I are going to talk about the fact that knowing and valuing yourself can help us both to address and eliminate burnout. There's an interactive loop, which we have explained has been ignored often, between the personal, the professional, the physical, and the social aspects of burnout. Debilitating overload caused by professional, personal, physical, and societal stress, or their combination, intensifies any unresolved issues from personal, intrapsychic, and relational sources. Having introduced the importance of the interactive loop, we're now going to discuss it in detail. Freudenberger, Herbert Freudenberger, a psychologist of German origin, in 1974 defined burnout as a state of mental and physical exhaustion caused by one's professional life. This definition was expanded, please, in 1993 by Maslach, who further defines burnout as having three chief components. You know about them: exhaustion, depersonalization, feeling that nothing you have done really matters and the importance of your work has stood for nothing, for naught. We're going to go into personal feelings of burnout that are very dangerous as we progress, individual personal feelings.
As you say, these are the three major components of burnout.
Yeah.
These are some of the demographic predictors of burnout. And it's been found in many studies that actually those of a younger age, under the age of 50, tend to be more susceptible. The more hours one works per week, the more one is susceptible to it. And of interest is that the female gender is 60% more likely than men to report burnout. They say there's a higher degree of emotional exhaustion and greater depersonalization. And the odds increase as they work more hours, more burnout occurs.
All right, I wish I could see everybody's faces. I'm asking you all, but I'm asking you, Stan, why is this?
Well, we've discussed this. The issue is
discussed this a lot.
That women carry more of a burden in terms of the home, much of the emotional life, than many men do in their relationships.
Mm-hmm. Mm-hmm. We work outside of the home, most of us, diligently, full work weeks, and many husbands are extremely involved in the well-being of a family, but usually the success of what happens in a family, the real communication in a family, depends on women. If doctors are burned out, and they are in every medical setting, other professionals in this setting are also impacted. Actually, what has led to these presentations that Stan and I are making is that because of my research and the high rate of suicide among doctors, especially younger doctors and women, I was invited to present locally at the College of Physicians in Philadelphia. This high incident led to the invitation, but it's important to understand that 300 to 400 physicians die by suicide every year. And nurses also die by suicide.
Yes, and you can see that the rate of physician suicide is 2.5 times greater than the general public. As SaraKay started to say, there are 3.4 million practicing nurses representing the largest group of healthcare professionals. Yet there's no clear data on the extent of nurse suicide, and this comes from a recent writing in the National Academy of Medicine, which is attributed below. To give you some interesting example, in the 7th year, after hearing and experiencing nurse suicides at UC San Diego, the HEAR program was extended to the nursing community. This was only in 2016. The HEAR program is the HEAR Education, Assessment, and Referral Program. So again, the nurse suicide rate is being recognized at this present time as well. This is, again, part of the national burnout assessment study that was done, that I alluded to, done by Medscape. They asked physicians several questions. Have you ever felt suicidal? 14%, yes, I've had thoughts of suicide, but have not attempted suicide. 1%, yes, I've attempted suicide. 80% said no, and 6% said prefer not to answer.
So, again, I ask, do you think the data is accurate?
No, I think many people probably would not say, and
right.
Also the 6% who preferred not to answer, I would suspect, did have some thoughts about it. This is a question which will be asked again and again. Is it burnout or is it depression? And there are arguments pro and con about its being a continuum. And there are two references below, one of which takes the position that it is a form of depression. The other argues strongly that it is not. It's important not to miss if depression appears because the risk of suicide increases. There is a concern, realistic concern with the diagnosis of depression because of the stigma and effect on physicians' sense of themselves, but also in a practical sense on licensing and hospital privileges. Although these have improved, there is still this issue of stigma. There has been work by the state medical boards to offer safe havens. Will diagnosis prevent going for care? My own bias is that they should be separate. There is no, at the current time in the DSM-5 for the psychiatric coding, there is no code for burnout at the present time. From a practical point of view, if everyone who feels that they are burnout is given the label of depression, I think that there will be many, many people leaving the profession, many people will not be able to get their privileges, and many people will not seek appropriate care because of the concerns of the stigma about this.
I couldn't agree more with that, Stan. But I'd like to give you an understanding of how for 40 years I've been treating depression successfully. When there's situational depression, it's usually caused by betrayal, connivance, illness, death, divorce, the loss of a job, and the talking cure really is effective sometimes with short-term medication. Another cause is a realization that you're not living the life you wish. Perhaps you're living the life of another that another expects you to live. And I sort of think that this is a form of unfinished emotional business. There's so many examples of this, but just briefly, I recently completed treating a woman whom I'll call Leslie, a gifted writer, longed to write, but whose mother so wanted her to enjoy with her the practice of law, which she did and was miserable. Leaving the practice of law, which eventually her mother understood so that she could write full time, completely alleviated her depression. Sometimes there is a combination of burnout, of overload, and depression. A client I worked with about a year ago felt totally responsible for the well-being of a sister 3 years older who had had polio as a child and was forced to see herself as unable and unattractive because of this. And this is what her parents felt was necessary for her to feel in order to feel cared for. And the burden of that care went to my client. She was on overload, she was burned out, and she was depressed because her sister had not been given permission to have a life. That was addressed. I want to tell you that the two sisters are now each thriving. Sometimes, however, with depression, a black cloud descends and you don't know why. You can't find a reason. Winston Churchill called this the black dog. Here, medication is essential, and I would also recommend to keep a patient talking until that black cloud lifts. With burnout, there's always a feeling, which is distinct from depression, of extreme overload, not knowing what to do first, and a feeling of complete loss of autonomy, which also is felt with depression. But Stan and I think here's how you can tell the difference between if you're suffering from burnout or depression. You go on a vacation, you go on a holiday, and if it's burned out at the end of the holiday, if it's burnout, you're going to feel better.
Yes.
If it's depression, you're not, unless you're burned out because of the people you're sharing with on this holiday, and in that there are issues to be fixed.
Yes. This is a slide that may be familiar to many of you. This is the current concept of how we care for populations and care for people. It's the Institute of Healthcare Improvement, Triple Aim, which was proposed in 2008, and it led to the idea of improving the health of populations, improving patients' experience of care, including quality and satisfaction, and reducing the per capita cost of care. This is the idea with many of the insurance companies and certainly behind the Affordable Care Act of looking at populations that the responsibility goes beyond the hospital and at the same time trying to reduce the cost of care.
So what's missing in the Triple Aim?
Well, we're going to get to that.
I bet attendees are guessing already.
This is a study about quality and patient safety. This is an extremely important study that was just released at the end of 2018. It was a meta-analysis of all of the studies, all 47 of the studies on over 42,000 physicians, and found that burnout is associated with a twofold increased odds for unsafe care, unprofessional behaviors, and low patient satisfaction. And it was a depersonalization dimension that had the strongest between this. The association between unprofessionalism and burnout was particularly high across studies of early career physicians, which is what we had stressed earlier in other studies. This is a study which we see here. It was recently published by ECRInstitute, in which they list on an annual basis the top 10 patient security concerns. And what we see is that burnout is listed as number 3 in its impact on patient safety. This is an amazing change in how we understand about the importance of burnout and its impact on not only on the caregiver, but also on the patients that we care for. So this is the missing aim.
Here we are.
The Quadruple Aim. 2015, it was found that you have to improve the clinician experience in order to successfully carry out the Triple Aim. As we've said, if you're inoperative, if you can't function, there's no way that you can do the thing that you need to do in terms of your patients and their well-being.
And this is the perfect segue to the next part of our presentation.
So this is the physical manifestations of burnout, and this was from 2011, that there was substantial evidence that part of it was not only the emotional, but there were physical changes as well. There was an increased likelihood of musculoskeletal disorders like back pain, headaches, etc., somatic complaints, GI symptoms, flu-type symptoms. So all of these which results in increased illness-related absences to work. The body may well be a readout of burnout experience in all areas.
And it's really important, vital, to listen to your body. For instance, if your neck is hurting, ask yourself, before illness sets in, who or what is my neck? If your back is hurting, who or what is breaking my back? If you're itching and there's no medical reason why, what is it you're itching for? What is it you can't stomach? What is it you can't swallow? This is an essential area of social burnout, excuse me, manifestations, from the most intimate involving partners and our immediate families to the outer concentric circles of friends and acquaintances. This is where burnout is often the most evident. In a study that I did, where a professional was so burned out at work that he was coming home in the most grandiose style, expecting to be catered to with every whim, his wife finally said to me, "Get off your pedestal. You're human just like I am."
Yeah. This is now a major part of our premise, addressing the healthcare professional-patient relationship, the real heart of self-care. The necessity of resilience. This is a definition of resilience from the American Psychological Association. Resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family, relationship problems, serious health problems, or workplace and financial stresses. It means bouncing back from difficult experiences. On the next slide, SaraKay offers another definition of resiliency.
You know, if you examine the literature on self-care, it is voluminous. But the emphasis is on the care and not on the individual self. Otto Rank has done some marvelous work in understanding, each of us understanding how individual each self really is. And he feels, Rank feels, and I agree, that fulfillment depends on becoming, if you will, whenever possible, the artist of our own lives, finding individual ways to achieve and internalize resilience, and then make sure that it's maintained. And as we move forward, we're going to give you actual strategies for you to examine and pick as your own arc force within yourself.
And this is about keeping resilience alive. We're about to make some important distinctions which will address and help prevent burnout. We're going to talk about the impact of compassion fatigue, countertransference, and vicarious trauma. What are the patient setting in society touching you? We're going to talk about establishing appropriate patient boundaries, an essential protection against burnout. And we're going to differentiate between pity, sympathy, and empathy. And then we're going to talk about the union of compassion and empathy.
And there's great a misunderstanding and differences of opinions about what these were, the definition of each of these words. And we're going to offer definitions that will help you address and prevent burnout. Yeah, so here are attendant syndromes, if you will, what is being touched in you. Compassion fatigue is always part of countertransference and vicarious trauma. On a micro level, compassion fatigue is caused by the emotional and physical fatigue experienced when treating patients who are suffering in some way. Helping a traumatized or suffering patient with no relief from the burden of this responsibility. On a macro level, it is caused by the impact of suffering, divisiveness, and mayhem, in a world with no relief in sight. Countertransference on a micro level was originally defined by Freud, and it's a result of patients' influence on practitioners' unconscious feelings. In other words, if an uncle was very unkind to you in your formative years and someone in your office reminds you of this uncle, you may understandably want to throw a chair or a bottle of water at him, or if it's an aunt, at her. And it's important to understand that you don't want to throw the water, but it's okay to have the feelings. Winnicott and Kernberg expanded the definition to include a broader experience of appropriate total reaction to patients, because obviously some are more likable than others, are more respectful to you than others. On a macro level, countertransference involves a reaction to impossible people and impossible situations, which all of us today are confronting. Vicarious trauma on a micro level refers to the emotions that result from knowing about a traumatizing event experienced by a patient and the stress from helping or wanting to help one traumatized and suffering. It is our empathetic ability which makes us particularly susceptible to emotional contagion and experiencing the very same feelings of the sufferer. On a macro level, vicarious trauma refers to the impact of graphic, painful material we're seeing day in and day out, death, violence, injury, in a world in constant turmoil, which obviously impacts our worldview and our sense of security.
What you're saying is these can lead to symptoms of post-traumatic stress syndrome.
Yeah, a lot of people are walking around with that reaction without even understanding it. So here we see the gauge is on empty, and Stan and I are stressing how, despite all of the upheaval around us, all that we don't know, all that's unsure in our world, it is possible and essential that we move from compassion fatigue to compassion satisfaction through appropriate self-care strategies, attitudes, and reframing. Compassion satisfaction was introduced first by Figley in 1995. What we know through research is that compassion satisfaction is positively associated with lower levels of burnout.
So it's very important to go from compassion fatigue to compassion satisfaction.
Which is our emphasis today.
Yes.
Next slide, please. The above is a common definition of compassion, and many people see compassion and empathy as the same, as Stan and I have said. But as we proceed, we're going to offer different and distinct definitions of each. Our emphasis will be, in addition to offering care and knowledge, introducing and stressing the importance of boundaries, the ability, the necessity to care but not carry. To follow this perspective, we're going to share the work of Carrie Gerdes, whose findings underscore the importance of boundaries, the ability, the necessity to care without carrying.
As we said earlier, we're going to make important distinctions between pity, sympathy, and empathy, and we'll start with pity. Early in history, pity was thought to be the same as sympathy and comparable to empathy. If you look at Michelangelo's Pity, Pietà, it's very easy, not easy, but one looks at this and has great sympathy for Mary, who's holding the dead body of her son Christ on her lap. However, at this writing, pity is usually intended to be condescending. So in general, the general population interpret pity now primarily as a negative emotion.
I think when people express pity, we don't realize we're being condescending, but our patients will.
Yes.
And their reaction to us will impact on us, and they'll feel diminished.
Yeah.
Gerdes explains that sympathy denotes basically that we and our patients are the same. 1 + 1 = 1. There's no boundaries. And if we move on to a discussion of empathy, Gerdes explains a distinction between sympathy and empathy, which is so important in avoiding burnout. Our patients and we are distinct. These are my patients, we tell ourselves. I'm going to help them the most I can, but I must see them as separate from me. 1 + 1 = 2. Effective sharing with self-other awareness, emotional regulation, and perspective taking offers this relief of boundaries. And these are the boundaries that protect us from burnout. Empathy, the skill, the ability where we perceive and feel the world from the subjective experience of another. It is not about us. It is about the other, and that leads to empowerment and optimism. Stan and I are explaining in today's complicated world that pity is condescending, that sympathy is experienced as invasive and asking us to carry too much, that empathy encourages a mutually respectful professional relationship.
There are many definitions of empathy and compassion that we have studied, and we picked the definitions that are most important in providing burnout. This definition of the Jefferson avoiding burnout. Yes. In the Jefferson scale of physician empathy, the aspect that is emphasized here as a way of having a boundary is that the empathy is only, in this sense, cognitive. In other words, no affective. So if you understand the inner experiences of the patient, and you can communicate this understanding to the patient, which is critical, but it is not involving feeling. It is only the understanding of the patient problem.
And Stan and I are suggesting that when one feels and one is there in feeling with the patients we're privileged to see, with boundaries, burnout is avoided and burnout is addressed. And that necessary component is vital. Here's our definition of compassion: an active, motivated use of oneself to alleviate deep suffering of another, all of our hard-won knowledge and experience. And, next slide, it is the union of empathy and compassion that is the heart of the professional-patient relationship. The success of each relationship, the heart, the core, as well as our own well-being, depends on this interrelationship of empathy, the ability to perceive the world of another without becoming part of it, and compassion, empathy's active force and protector through the active use of oneself and all we have learned and all experience has taught us. This union brings the relationship balance necessary to protect us against burnout, and it makes the following possible.
Addressing burnout. This slide is going to be an overview of our next section. It's self-awareness and resilience. It's important to recognize the early signs of stress and its effect on the professional, personal, physical, and social aspects of one's life. Look first at the self and self-care strategies that help build resilience. Look to communities and resources within one's department, institution, medical, and other health groups for the other strategies and support that one needs.
So I said earlier that we're going to provide your signs of burnout if it's happening, and I said it's in the wings for us all for micro and macro reasons, so that you can eventually get moving with your self-care strategies to address it. You feel isolated, you feel hopeless, you're feeling inoperative, you're getting to be close to real important sharing with your colleagues, with your family. You're irritable, you're quick to anger, you feel worthless. And as burnout worsens, the overload makes you paranoid, you long to self-medicate and often do. You're depleted, you're exhausted, and you may decide to leave a promising career yourself or by being fired because you're just so overwhelmed. In addition to this, understanding what a patient touches in you is such an important goal. As we said, it's perfectly understandable if you want to throw a bottle of water at a patient or even a chair. We do not have to be pure in thought as well as deep. But if we understand what's going on in us and what patients or colleagues or those we report to touch in us, then we can be energized through awareness to move forward.
Yes.
We're stressing that compassion satisfaction enhances resiliency and is enforced by self-care strategies you select, and you can see them on the screen. Strategy selection is not one size fits all. It's important to choose the strategies that feel right for you. Remember the importance of thinking outside of the box and having fun. Remember to have a dream and to pursue it. And if one dream doesn't work out, there's only one thing to do. Find another. Remember the importance of saying no so that you have energy in your personal life for those you care deeply about. Take the time, as we've said, to know what you feel and to hope and to dream. Do not bury feelings by soldiering on. When things go wrong, learn from the experience, take it seriously. Do not take it personally. We're promised only the pursuit of happiness, remember? So during this very complex time, perhaps a wiser direction is to concentrate on the joy and fulfillment of important relationships and the fulfillment that comes from meaningful pursuits. With self-care and self-awareness and an understanding of the importance of boundaries, despite everything surrounding us, this is within our reach, and we must give ourselves the gift of time, permission, and place to make it happen.
Very good. Very good. Important points. Again, the interactive loop, physical self-care, you certainly can't ignore any medical or dental problems. You have to sometimes have a masseuse, chiropractor. It's important to be in contact with others, take care of yourself, get your sleep, sick time, vacations. We talked about the importance of vacations as a way of getting away from the pressures that you have from your work and the patient's demands on you. Again, it's personal. If you hurt yourself every time you attempt to work out, there are other physical options.
My husband got this into the slide. I didn't see it. He's talking about me. Every time I get on one of those machines to work out, the machines and I don't get along, and I get hurt. So we ballroom dance whenever we can.
Yeah.
And we walk. Okay, in social, Stan, you didn't tell me, you didn't show me. Okay, in social self-care, it's very important to give the necessary time to nurture your important relationships and to make time for your friends. One is not a physician to friends and family. A partner needs a partner, a child needs a parent. It's important to remember in marriage that marriage involves really three living entities: you, your partner, and the marriage you must both contribute to for it to stay alive and rewarding. Sometimes change is necessary in every important relationship. Sometimes there's a need for an intermission. Sometimes there's a need to let go. I love the work of Dr. Jeffrey Grice at the University of Pennsylvania, who says that one person can't fill all our needs. There are must friends, small circle who we tell all important things to, the trust friends, a larger circle, but we know they're true to us, the rust friends, the people who know of our background, and we can say, do you remember when we went here or there? What did happen at that anniversary party or at even that prom? There's the just friends, the people we just have a good time with. And to this paradigm, I've added the dust friends. Sometimes by default or design, we just let go. Important relationships, as said, sometimes need an intermission. Sometimes a letting go process in important relationships, personally and professionally, call for a change.
There are examples of what your institution can do to improve the clinician's experience that are based on evidence-based practices. It's important, as we said with the Quadruple Aim, you have to focus on the staff as well as the patient. Improvement in caregivers' lives leads to enhanced patient care. That's been shown again and again. And this emphasis enhances staff engagement and retention, as does leaders' interaction and consultations with staff. The goal is to create an open environment for shared feedback and learning. A little slide change over here. Sorry.
There we go.
There we go. We had talked about this study earlier, the PRC study, and basically how can one improve the nurse engagement. And there were three drivers of engagement listed here. Basically, if you recall, the burnout in the engaged patients, engaged nurses, was much less than those who were not engaged. And what they talk about here is that nurses need autonomy. They want to be fully engaged, active participant in decision making. There wants to be, the nurses look for teamwork and collaboration. And nurses are more likely to be fully engaged if leadership is accessible and responsive to them.
It's a special time for nurses this week.
Yeah, apparently.
It's Nurse Appreciation Week. I always tell Stan that doctors are the heart of medicine, nurses are the ears. Congratulations and thank you so much for all you do. It's impossible without you.
These are some examples of what institutions have done to help in this professional fulfillment. This is Stanford, which was a leader in setting up a wellness center many years ago. Again, they emphasize the culture of wellness, the efficiency of practice, and personal resilience. This is an approach that comes from the Cleveland Clinic, where they have established a code lavender, cultivating intentional acts of kindness in response to stressful work situations. If someone on the floor has an emergency situation where they are really acutely under stress because of some problem which has occurred with a patient, perhaps a patient death, they can call Code Lavender. Brigham and Women's have a center for professionalism and peer support as well. Peer support is very, very important. Medical schools have been changing their curriculum, and if they have less hours, scheduling, grading electives, etc., required study courses in resilience, mindfulness, this has been associated with lower levels of depression symptoms, anxiety, as compared to students who did not have them before this was put in place. Vanderbilt has actually set something up where they have student-run initiatives, 5 committees, and if you look at them, they sound a lot like what we've been talking. Different areas of student well-being, the physical, the emotional, spiritual, interpersonal, academic, professional, and then the environment and community.
Everything we've been saying.
Everything we've been saying, yes. Now, these are some of the specific work-related activities. The AMA Steps Forward program is outstanding on this. They have work on vastly improving the physician-computer interface, and encouraging teamwork and team support. And there are modules in many, many areas relating to the things we discussed earlier. Again, there's a plethora of resources on burnout and wellness. The AAMC, Association of Medical Colleges, now requires in their training programs to be accredited. Psychological, emotional, and physical well-being are critical in development of a competent, caring, and resilient physician. Sufficient physician well-being, etc. All of these things are critical and are available.
Wrapping up, we've reviewed the macro and micro causation of burnout, the interactive loop of personal, professional, social, and physical aspects of burnout, and the importance of resilience and self-care strategy, individualized, selected self-care strategies. We've emphasized the importance of boundaries to care but not carry, and reframe perspectives in the professional-patient relationship. Everyone cherishes a garden, and what Stan and I have been concentrating on today is your own unique inner garden, one that can be visited with regularity in order to restore energy, reflect, plan. We hope we've offered some new perspectives and framing to assist you as you chart your course in these extremely challenging times. We're going to go on to questions and discussion, but first it's important to thank you so much for inviting us to share with you.
Yes, thank you.
Thank you.
Thanks, Dr. Smullens and SaraKay, for a fantastic presentation. That concludes the slide presentation of our program. We'd now like to begin our question and answer period. If you have questions, please type them in the Q&A box found at the bottom of your screen. You'll have to hover over the bottom portion of your screen and click on the three dots to open the Q&A. Then direct them to all panelists, and we'll try to get to as many questions as we can. I actually see that our first questions come in. The person I report to is demeaning to me. What are my options?
Well, it's not acceptable for the person you report to be demeaning to you. So you need to be asked, you know, every partner in an intimate relationship should ask his, her, their partner, how is it going for you? How can our relationship improve? Anyone you report to in a professional setting should be asking you, how are things going? How can we improve the resilience so necessary to function in today's complicated society? What can we do to make your job easier? And it's important, if you're being demeaned, to say to the person who's demeaning you, I really am not comfortable with some of the ways you're treating me. One of the, Jan and I have been honored to speak to the Jefferson medical students, and we spend a lot of time with female staff, helping female staff to address disrespect seen in the hospital population, in patients. It's just not acceptable. Jan?
You're right. Right, and one of the principles that we teach in terms of the culture of safety is to be able to speak up.
Right.
If you can't speak up, then you're not going to have a culture of safety. And if you try to speak to your supervisor and you're getting no response, although the chain of command is something you learn in the service, you have to go around the chain of command to the leader.
Yes.
You really cannot accept that kind of behavior.
Yes.
Okay, I see another question's come in. The participant asks, what is the most appropriate way to show my patients that I care?
Well, one of the most important things is to spend some time with them. It's been shown that just 40 seconds of being with a patient and listening to them, looking them in the eye, giving them your full attention is really about the most important thing that you can do. You have to let patients see you, let them know that you understand their problem. You are doing all that you can to help them, that you're working together as a team, and this will be very, very good for you as the clinician and it'll be marvelous for your patient, helping them recover.
But in this technological revolution, there are so many people we have contact with, but we don't have the time for connection. It is healing. It energizes it. We must make the time for connection, but in a professional sense with boundaries. And at home sometimes being sympathetic without boundaries is not going to be helpful. Boundaries can help us really address problems and give all that we can.
Very good.
Yeah.
Okay. The webinar will be ending soon, but we have time for a few more questions. I ask our participants to continue to submit their questions. The next question, what is the best way to proceed in arranging self-care strategies?
Well, I think it's very, very individual. And
right.
As SaraKay was trying to emphasize, you have to figure out what works for you. And some of the lists of the personal things that you can do, journaling, meditating, yoga, all of these things are there. Learning to play an instrument, again.
Thinking outside of the box.
Yes.
If you've always wanted to act or help with sets or theater, find a place to express that. You don't always have to read or see films that are meaningful and informative. I try at least every 10 days on an afternoon where I'm not scheduled to take a wonderful cookie I like with oatmeal raisins and go to a movie alone and have coffee and my cookie and just relax. It's so important to just take time for yourselves where you're just not pressured and you can just be. And
I know it's very hard in a competitive world.
Right.
Sometimes it's absolutely necessary for your own well-being to say no. I just can't do another shift.
I need time for myself. I need time for my loved ones. I need time for my recreation.
Definitely agree. Another question, what is the best way to set up a wellness program in my setting?
I think it varies on, of course, obviously in your setting. Is it an office practice? Is it a practice in a large clinic? Is it a hospital setting? I think there is more and more awareness and more receptivity to understanding that taking care of the caregiver is critical for improving the patient's sense of how well they are doing, and even they're better in better outcomes by the care that they get and the concern that's shown to them. So I think it's important in your organization, if you do not have such a wellness program or any kind of activity, that you have to go to the leadership. If it's a group of many practitioners, then you have to get together and decide, look, we've got to do something. We've got to figure out what it is we need. Some practices arrange to have laundry picked up for the people in their practices just to save time, or some other activities. Something in it where you can have.
I would like that at home.
So you have to have a setup where first of all, the leadership understands that this is absolutely necessary to be a successful practice. Then you have to figure out what works best for you.
Sometimes in these presentations that Stan and I have been honored to share, people have questions later after thinking about things, and we want to make sure that you have our email address in case somebody might want to get in touch with us.
So I think they will be supplied to us. If you have a chance or you want to write it down, mine is stanton.smullens@jefferson.edu.
And I'm SaraKay, SaraKay, one word, capital S, capital K, 1710@gmail.com.
Well, Dr. Smullens and SaraKay, thank you so much for this insightful presentation. I want to thank everyone for joining us today. This concludes our webinar.